Adult schistosomes cause negligible harm. However, this does not hold true to their other forms, particularly the eggs, which contain potent proteolytic antigens. Conveniently, the natural history of all schistosomal infections can be described in 3 stages. The stage of penetration, which may cause, quote, swimmer's itch, the stage of maturation and egg release, known as, quote, Katayama fever, and the stage of established disease, the consequence of long-term steady release of antigenic eggs which can cause irreversible tissue damage if left untreated. Swimmer's itch is a host hypersensitivity reaction that occurs with Cercariae invasion. It typically presents within hours after infection as a pruritic papular rash, as shown on this slide, with edema, erythema, and eosinophilia which resolve spontaneously within 10 days. Swimmer's itch is common among travelers who become infected for the first time, while it is rare in people living in endemic areas due to repeated exposures and partial tolerance to the parasite. Katayama fever is a rare but severe inflammatory immune response to the eggs of schistosomes that are unable to be successfully released into the urine or stool of the host. It typically occurs between 1 and 3 months after the primary infection, the stage of penetration, when the female parasite begins egg production. The embryos within the eggs secrete highly antigenic lytic materials, resulting in a hypersensitivity reaction and the development of a granulomatous inflammation. This stage of disease clinically manifests itself with symptoms of fever, chills, rash, headache, cough, nausea and vomiting, abdominal discomfort, hepatomegaly, lymphadenopathy, marked peripheral eosinophilia, and diarrhea with blood, mucus, and necrotic material for weeks to months. Katayama fever occurs more commonly with S. japonicum, given that it has a higher rate of egg production and more extensive gastrointestinal involvement. Lastly, the clinical manifestations of the established disease are dependent upon the species of the parasite. S. mansoni is the most widespread of the schistosomes. The eggs of S. mansoni have a characteristic lateral spine, as seen in the upper right image, which can be deposited in the intestinal wall near the inferior mesenteric venous plexus, resulting in recurrent bloody diarrhea, colitis, and prostatitis, as seen in the lower right image. Additionally, these eggs can be swept back up into the portal system, causing pre-sinusoidal portal granulomas and fibrosis with progressive portal hypertension, hepatosplenomegaly, and ascites. S. japonicum is endemic in Asia, particularly in China, Indonesia, and the Philippines. The eggs of S. japonicum have a uniquely small size, in part due to their minute lateral tubercle, as illustrated by the arrow in the left upper image. Infection with S. japonicum closely resembles that of S. mansoni. However, symptoms tend to be more severe and may have small bowel involvement, given that S. japonicum produces 10 times more eggs than other schistosomal species. Additionally, other organs may be affected, including the lungs and the brain, given that the eggs are significantly smaller than other schistosomal species. Lastly, S. japonicum is the only schistosome that can infect other hosts, such as cats, dogs, and cattle. S. hematobium is endemic in Africa, the Middle East, and India. The eggs of S. hematobium have a characteristic terminal spine, as seen in the upper right image. Early in the disease, it is generally benign and usually not accompanied by any significant clinical manifestations except intermittent painless hematuria. In hyperendemic regions like Egypt, the disease is so common that it is not even considered an illness. In boys, it is accepted as an early phase of adolescence similar to menstruation in girls, as seen in the lower right image. However, cystitis, urethritis, ureteric obstruction, hydroureter, hydronephrosis, and secondary bacterial infection, particularly with salmonella, can commonly develop late in the disease. Furthermore, S. hematobium is a proven risk for squamous cell carcinoma of the bladder. S. mekongi is endemic to the Mekong River Basin, of China, Laos, Thailand, and Cambodia. Its eggs, with their small size and minute lateral tubercle, as shown on the right, and clinical manifestations closely resemble that of S. japonicum. Finally, S. intercalatum is endemic in Africa. Its eggs have an oval shape with a slightly bent terminal spine, as shown on the left. Infection with S. intercalatum closely resembles that of S. mansoni, but is milder in disease severity.